Good morning. We will now study the disorders of the skin. And before we study the disorders, we will begin with the discussion on the lesions because these are the clinical manifestations that we will be encountering later when we study the diseases. First, a macule. Now, a macule is an area of hyperpigmentation or hypopigmentation. So it is a flat, tough, non-elevated lesion. So larger than a macule is a patch. So the crucial size that you need to remember is 5 millimeters. Less than 5 millimeters, the flat topped non-elevated area of discoloration is called a macule. Larger than 5 millimeters, that lesion will be called a patch. So that discoloration will come in the form of hypopigmentation or hyperpigmentation. Another lesion is the papule. A papule is now an elevated lesion. So larger than papule is a nodule. Okay, so this is an example of a nodule. Again, the cut size that you need to remember is 5 millimeters. An elevated lesion that is less than 5 millimeters will be called a papule. Larger than 5 millimeters, a nodule. Okay? Another lesion is a plaque. A plaque is a flat-topped elevated lesion. This is usually the lesion that you will be able to see in ringworms, plaque. Now, vesicle is more commonly known in layman as blister. So, larger vesicles are called bullae, singular bulla. Again, the differentiating size is 5 millimeters. So, fluid-filled lesions that are less than 5 millimeters in size are called vesicles. Fluid-filled lesions that are measuring more than 5 millimeters are called bullae. So these lesions are more commonly seen in chickenpox. Another type of lesion is characterized by the presence of pus. So that is why they are called pustules, pus-filled lesions. Okay, so the picture that you are seeing right now is bacterial folliculitis, presenting as pustule in the hair follicles because of infection, bacterial infection in the hair follicles. Now, allergic reactions will produce these lesions. Elevated, red, and most of the time itchy. So these lesions are now called let us go to microscopic description of skin lesions. Elevated lesions. When we say hyperkeratosis, it means there is increased thickness of the stratum corneum, which results from increased keratin formation. So usually you will be able to see this in warts. And then parakeratosis means there is retention of the nuclei in the stratum corneum layer. Remember, in normal stratum corneum, you will not be able to see nucleus anymore because the cells in that stratum are already dead. But if they are still present in the stratum corneum, then the condition is called parakeratosis. Again, this lesion will be seen in warts. Hypergranulosis, as the name implies, you will be able to see numerous granules in the squamous cells. So, not limited only to the stratum granulosum. And then acanthosis is a more specific term that will denote hyperplasia of the epidermis. Okay? So, hyperplasia of the epidermis is also called acanthosis. Now, whenever there is acanthosis, most of the time you will be able to see also papillomatosis. It means there are finger-like projections of the dermis into of the epidermis into the dermis. Again, this results from hyperplasia of the epidermis, so that numerous projections are produced by the epidermis into the dermis. And then this keratosis means the presence of keratin in the lower layers of the epidermis. Remember, keratin is present in the stratum corneum only. If keratinization occurs in the stratum granulosum, spinosum, or basale, then the condition is called dyskeratosis. And then acantholysis means there is separation of the squamous cells from each other. That is why a space is produced in the epidermis. And then, whenever that space is filled with water, it will now be called spongiosis, microscopically. This is now spongiosis, a space in the epidermis that is filled with edema fluid because of separation, because of acantholysis, separation of the squamous from each other. So hydropic swelling refers to edema of individual squamous cells. Okay? Now, exocytosis is a controversial term because it means the infiltration of the white blood cells. In this condition, we are seeing lymphocytes infiltrating the epidermis. Normally, there is no white blood cell in our epidermis. If you will be able to see white blood cells in the epidermis, then that condition is called erosion. Now, and exostosis. Erosion means there is a defect affecting the epidermis only, the excavation of the epidermis. If the excavation now affects the dermis, then the condition becomes called an ulcer, which is deeper in involvement than erosion. And then vacuolization refers to the presence of vacuoles or spaces within the cytoplasm of the squamous cells. And then lentiginous refers to the pattern of spread of a lesion in the epidermis. So most of the time, this pattern of spread is used in pigmentation lesions, such as in malignant melanoma or in nevi. So it means it refers to the lateral spread of an abnormality in the epidermis. So when you say lateral, is still confined within the epidermis, and then the lesion is spread not into not deep into the dermis, but remains only in the epidermis. So lateral spread of the lesion, lentiginous. That on microscopic examination, what you will be able to see in the epidermis is the loss of the melanocytes in freckles. So usually, the occurrence of this lesion is influenced by the race of the individuals affected. Usually, you will be able to see freckles in Caucasians, in lightly pigmented individuals. Now, another abnormality in skin pigmentation is melasma. It is more commonly called the mask of pregnancy because its occurrence is associated with pregnancy. So sometimes it is also associated with use of oral contraceptive pills, but most of the time you will be able to see melasma in pregnant females. So what you will be able to see are areas of hyperpigmentation, tan to dark brown macules, which may be accentuated by exposure to sunlight. Now, you will be able to see three types of histologic abnormalities in melasma. So the increased pigmentation may be seen in the epidermis only. Or there are forms of melasma wherein increased melanin pigments are seen within the macrophages in the dermis, not in the epidermis. And then the third morphologic pattern or histologic pattern is a mixture between dermal and epidermal types, so that melanin pigments are seen in these two layers of the skin, epidermis and dermis. Okay? So the basic problem in the development of melasma is increased transfer of melanin pigments from the melanocytes to the squamous cells or to the macrophages in the dermis. So the exact mechanism on how this condition develops increased transfer is not yet fully understood. Sometimes it is associated with this condition. Use of this drug, most of the time it is idiopathic. However, it is associated with pregnancy. Another abnormality in pigmentation is lentigo. What you will be able to see here are these lesions, small oval to tan brown patches. So the problem with this condition is increased number of melanocytes in specific areas of the body. So what you will be able to see here under the microscope is the presence of melanocytic hyperplasia, increased number of melanocytes that is spreading laterally only, lentiginous, within the stratum basale layer only. So because of that, because of the increased number of melanocytes, there is also a corresponding increase in the melanin pigments produced. That is why the basal layer becomes hyperpigmented. Now let us go into the moles. So they are called nebi or nibus. So nebi are actually neoplasms of the melanocytes, meaning there is increased proliferation of the melanocytes. So this condition can be congenital or acquired. So there are numerous subtypes as indicated in your book. So there are moles which are flat and will present only as hyperpigmented macule or patch depending on the size of the lesion. So majority of moles, however, are elevated. So elevated and then hyperpigmented in comparison with the rest of the skin because it is composed of increased number of melanocytes with corresponding increase in production. Okay, under the microscope, what you will be able to see nearby are proliferating nests of melanocytes, which will be seen as round cells. So there are three types of nebi according to the location of the proliferating melanocytes. As the name implies, intradermal, okay? So the melanocytes are seen in the dermis only. And then junctional nebi, junctional nebus means the proliferating melanocytes are present at the junction between the epidermis and dermis. Usually they're located in the stratum basale. And then a combination of junctional and intradermal, meaning the proliferating melanocytes are seen both in the epidermis and in the dermis, then it will be called compound nebus or nebi. So that's a picture showing us a junctional type of nebus. And then this is a picture that will demonstrate to us a compound type of nebus where we will be able to see junctional nebus and intradermal nevus. And because the proliferating melanocytes are seen in these two layers, then it will be called a compound nevus. Now, one very important property that you must remember about nevus is the maturation of the melanocytes. When you say maturation, okay, it means that you will be able to see melanocytes with larger nuclei and arranged into nest in the superficial layer of the skin. And then in the deeper layer, you will not be able to see this arrangement anymore, nesting pattern. So they will be seen in cords or in sheets. And usually the deeper, the melanocytes that are located in the deeper dermis will have no melanin pigments anymore. Okay? And then they will show smaller size of their nucleus. So these features are very important to remember because they will be lost. They will not be seen in malignant melanoma anymore. So that what you will be able to see in malignant melanoma are cells which are mostly in nest, and all of them will display large size of nucleus, even those which are located in the deeper layers already. And pigments will also be seen in the deeper layers. So one form of nevus serves as a transition from benign to malignant, the dysplastic nevus. Now, look at the look at the margins now of this nevus. It is highly irregular, unlike the benign, which is well circumscribed. Okay, so highly irregular margin, and then the degree of pigmentation is not uniform all throughout the lesion. You will be able to see darker colored areas at the center of the lesion. And then the peripheral portions of the lesion are slightly lighter than the central portion. So that's the clinical appearance of a dysplastic nevus. Okay, so you will be able to see a target-like variegated lesion. Variegated because there is variation in the degree of pigmentation. Target as shown in the diagram. So this lesion may occur in sun-exposed or non-sun-exposed area. Not a problem with dysplastic nevus. Look at its name, dysplastic. It is already characterized by the presence of mutation. With more mutations that will develop in a dysplastic nevus eventually, it may evolve into malignant melanoma. So what you will be able to see in a dysplastic nevus is a compound nevus. So, so the proliferating melanocytes are seen in the epidermis and in the dermis. Okay, so there may be fusion of the nest of melanocytes within the stratum basale, forming a lentiginous pattern of spread. And then we will be able to see cytologic atypia already. When you say cytologic atypia, you will be able to see large nucleus all throughout the layers that will display all throughout the melanocytes. To all melanocytes, they will display large nucleus with large nucleoli also. So aside from the characteristic abnormality that will be seen in the nucleus, the dermis will also display these abnormalities, lymphocytic infiltration. So because of increased production of melanin pigments, we will be able to see melanin pigments phagocytosed by the dermal macrophages, and then there will be linear fibrosis surrounding the pegs, ridges. So this is now the dermal fibrosis surrounding the retipegs of the epidermis. And then we'll be able to see proliferation of the melanocytes in the junctional layer and proliferation of melanocytes in the deep dermis layer. So, junctional type of proliferation. And then when you shift to high power magnification, you will be able to see large nuclei with visible red colored to pink colored nucleoli. And then the malignant form of the nevi is the malignant melanoma. The problem with malignant melanoma is that it is highly metastatic. Most of the time, you will be able to see lymph node enlargement in malignant melanoma. So this may occur in many areas of the body, including those which are located, which are supposed to be not exposed to sunlight. So anogenital region inside the oral cavity, esophagus, meninges, and the eyes, because these areas of the body will still possess normally melanocytes. So the risk factors are the following. The main risk factor is prolonged exposure to sunlight. Okay? So malignant melanoma is highly variable with regards to clinical manifestation. So patients may complain of no symptom at all, or some may complain of itching. So the size is highly variable also, but usually it is larger than 10 millimeters with irregular borders, just like what you have seen in this plastic nibus. So if you have a mole that is exhibiting sudden change in color, size, shape, then you must have that mole biopsied. So remove for biopsy to be able to determine if that mole has already degenerated into malignant melanoma. Okay? That's the characteristic appearance of malignant melanoma. It will look like this plastic nibus, but remember, this plastic nibus will have a target-like appearance, meaning the area, darker areas will be seen at the center only. In this form, this lesion, we are seeing dark areas anywhere in the lesion, not anymore presenting as target-like in appearance. So, under the microscope, we may be able to see two patterns of growth. Radial, meaning the spread is within the epidermis and superficial dermis only. Vertical is associated with more aggressive behavior of the malignancy. It means there is invasion of the deeper dermis already. So, in the assessment of malignant melanoma, the following factors are included. Number one, depth of invasion. Number of mitotic figures. The higher the mitotic activity, the greater is the probability of metastasis. And then degree also of lymphocytic infiltration. The greater the number of lymphocytes that are present among the malignant cells, the higher is the probability for metastasis. Okay, so look at this picture of malignant melanoma. We will be able to see great number of lymphocytes infiltrating the dermis, accompanying the malignant melanocytes, which are now being pointed. Okay, so another picture showing us malignant melanoma. Again, there is loss of maturation pattern in malignant melanoma. So that the size of the nuclei in the cells in the deeper regions will be almost the same with the size of the nuclei of the cells located in the superficial layers of the skin. Now, this is highly characteristic for malignant melanoma. On high power magnification, you should be able to see large pleomorphic nuclei with very prominent and large pink to red colored nucleoli. And you will have a clue that these malignant cells are melanocytes because sometimes you will be able to see melanin pigments in some of the malignant cells. So these are the factors that are considered in determining the outcome of malignant melanoma. So these are factors that will provide favorable outcome to a malignant melanoma. First, if the depth of invasion is less than 1.7 millimeters. So the invasion is usually measured from the dermal epidermal junction up to the most deep portion of the dermis that is infiltrated by the malignant melanocytes. And then evidence of immune response to the radial growth component, meaning the presence of the lymphocytes. So if there is absence or less number of lymphocytes in accompanying the tumor cells, then it is associated with good prognosis. So if there is low mitotic count, meaning there is a slower proliferation of the tumor cells. And then presence and degree of the infiltrating lymphocytes, as discussed a while ago. And then most of the time, females will have better outcome of this malignancy compared to males. The exact reason for that is not yet fully understood. So this is according to statistics only. And then better outcomes are seen when malignant melanomas arise in the extremities. So these factors, increased thickness, presence of ulceration, will markedly increase the aggressiveness of the needle. So we have finished the commonly encountered abnormalities of the skin characterized by change in pigmentation. Now we study this group, benign epithelial tumors. Keratin. So in this increased keratin will not be limited in the stratum corneum only. Usually, the keratinization will invaginate into the deeper layers of the epidermis, forming invagination cysts, which are called also as clinically, this is the lesion that you will be able to see. It will be a coin-like lesion, flat-topped, elevated lesion with hyperpigmentation. And then under the microscope, there will be proliferation of basaloid-looking cells accompanied by invagination of the keratin. So this lesion that I am outlining right now is called a pseudohorn cyst. So this lesion is now called the horn cyst. Horn because it is composed of keratin material. Another benign condition of the epidermis is acanthosis nigricans. So usually these lesions are seen in the plexural areas of the skin characterized as hyperpigmentation with velvet-like texture or surface. The cause is the hyperplasia in this layer of the epidermis, stratum spinosum. So this hyperplasia is secondary to stimulation from growth factors. So these growth factors are not produced in the epidermis itself. So these growth factors come from a variety of tumors occurring elsewhere in the body. So that acanthosis nigricans may serve as the marker for the presence of a tumor in other areas of the body. This tumor may either be benign or malignant. This tumor may either be benign or malignant that are producing growth factors, stimulating the proliferation of the cells in spinosum. So there are two forms of this condition. The benign is usually encountered in childhood or in puberty, the malignant in the older age group. So the benign form is acquired via autosomal dominant pattern. So this also usually associated with obesity and endocrine abnormalities. So if you see a child that is obese, examine the flexural areas of the skin. If you will be able to see dark pigmentations, then you will be able to come up with this diagnosis, acanthosis nigricans. So nothing to worry, because most of the time in children, this condition is benign and associated with endocrine abnormalities or obesity. So the problem is acanthosis nigricans developing in older age group. Usually it is associated with the presence of a malignancy in the gastrointestinal tract. So gastrointestinal tract adenocarcinoma that is producing growth factors that will go to the skin and produce proliferation, stimulate proliferation of the squamous cells. So these are the lesions that we will be able to see under the microscope. So there will be valleys and peaks of undulating epidermis and dermal papillae. So there will be variable acanthosis or hyperplasia of the epidermis, which may be accompanied by hyperkeratosis. The darkening of the skin is secondary to increased melanin pigmentation without proliferation of the melanocytes. Another commonly encountered benign skin lesion is fibroepithelial polyp. It is more commonly called a skin tag or an acrocordon. So it is commonly seen in this age group, middle-aged and elderly individuals with a predilection of these areas of the body, neck, face, and then the trunk. The exact mechanism on how this lesion developed is not yet fully identified. So microscopically, you will be able to see a core of dense, irregular connective tissue and covered by benign epidermis. Okay, so because all tissue components are benign, then the behavior of this condition is also benign. So another commonly encountered benign skin lesion is the epithelial cyst or wen. In your surgical rotation later, you may have a chance of excising this benign lesion of the skin. So it results from the invagination or cystic expansion of the epidermis or the epithelium of the hair follicle, which is still composed of epidermis. So under the microscope, you will be able to see a cyst that will be filled with keratin or lipid materials coming from the sebaceous gland of the hair follicle. So this is a well-circumscribed lesion, and then clinically, you will be able to examine a firm and movable nodule under the skin, usually in the dermis. The key word here is movable. Should be movable because malignant lesions are usually fixed to the surrounding connective tissues. So there may be several types of epithelial cyst. The first type is the most commonly encountered. So it is called the epidermal inclusion cyst. So the wall of the cyst is lined by benign epidermis and then it will be filled with keratin. And then it is called a pilar or trichelemal cyst when the epithelium lining the cyst looks similar with the epithelium lining the hair follicles. Okay, so there is great likelihood that this cyst must have developed from the hair follicles. So dermoid cyst is the term used to denote an epithelial cyst that is still lined with epidermis but now accompanied by skin appendages, meaning the epidermis becomes accompanied now by sebaceous glands and sweat glands. And then cyst is called steatocystoma multiplex when the wall resembles the histology of the sebaceous gland duct. Now we go into this group, adnexal tumors. So this group is composed of wide spectrum of benign neoplasms that originate or arise from the appendages of the skin, meaning arising from the hair follicle, sebaceous gland, or sweat gland. So these are the commonly encountered types. So clinically, you will be able to see these tumors as nodules and covered by regular skin, so that there will be no pigmentation or hyperpigmentation or hypopigmentation. Regular color of the skin presenting as nodules, which may be solitary or numerous. So that is how a cylindroma will look like. So that is also the area of preference in the forehead for the development of cylindroma. So cylindroma arise from apocrine sweat gland, so with apocrine differentiation. So it is composed of islands of cells resembling the normal epidermis or basaloid cells. Characteristic pattern of arrangement is the jigsaw arrangement of the islands of the tumor cells in the dermis. Okay? So the jigsaw pattern of arrangement of the tumor cells in cylindroma. Another skin adnexal neoplasm is trichoepithelioma. And this is also the characteristic pattern of distribution in the skin, affecting the face in this triangular area. So, and then another benign appendixal tumor is trichoepithelioma. So again, this condition arises from the epithelium of the hair follicle. Okay, so that under the microscope, what you will be able to see is the proliferation of basaloid cells forming primitive structures that will resemble the hair follicles because they arise from the epithelium of the hair follicle. Okay, so you will be able to see proliferation of the basaloid cells, and then you will be able to see spaces that will resemble the spaces housing the shaft of the hair. Okay, so keratoacantoma is actually a benign neoplasm. The problem with this neoplasm is that it mimics the appearance of squamous cell carcinoma both clinically and microscopically. Okay? So, and because this is a benign condition, this will have this clinical behavior. It heals by itself spontaneously. So this is how a keratoacanthoma will look like. It looks like a malignant tumor of the skin. Under the microscope, you will be able to see this lesion. So where there is proliferation of the squamous cells, and these proliferating squamous cells are now infiltrating the deeper layers of the dermis, so that you will be able to see this is the normal basement membrane of the epidermis. And because there is hyperplasia or acanthosis, that the epidermis now is seen in the deeper layers of the dermis. So we are able to see acanthosis papillomatosis, and dyskeratosis. So keratin is now seen in the deeper layers. Normally, keratin is present in stratum corneum only. Okay, so a better picture showing us this keratosis, keratin formation in the deeper layers of the skin. Okay, so that ends our first session for the disorders of the skin. We will discuss this group of neoplasm in our next meeting.